binding proteins are important. We've discussed that binding protein typically are required for steroids, but rarely also for peptides like growth hormone, which are bound. Now, what are the binding protein doing? One, they are taking as a transporter. It's like a boat ride. You're going from one place to the other. So they are taking hormones like peptide hormones, like growth hormone, they're taking to the particular site. You've got steroids which are going to bind with the binding protein. So they play an important role in navigating them to a particular thing. And you will have a binding protein which is going to work out from that perspective. So now binding protein, because you may have other effects in terms of the biochemical assays, can have significant implications. So 10-year-old girl with poor concentration, height is reasonable, it's clinically euthyroid, but your T4 level is low, TSH is normal. Yes. So this could be a central hypothyroidism, but because central hypothyroidism is rare, we should go ahead with confirmation. We found that the free T4 level here was on the lower side, and this was more like a TBG defect. So clearly, before you're looking at in terms of interpreting unusual thyroid functions, especially with a total thyroid, always think of a binding protein abnormality, which is there in terms of assessment. The second important factor is binding protein may actually guide you to a particular site. It's not just that you are sitting on there and you go anywhere random. Sometimes they will act like a chaperone. And here I always give a classical example of growth hormone binding protein. So growth hormone binding protein is the extracellular domain of the growth hormone receptor. So where will it be produced from? Yes. So it will be the growth hormone target tissues. So they are in a way attracting. They are sending signal. Okay, it's like a bait. It's going there and then they are pulling out. So typically the growth hormone receptor, the growth hormone binding protein is coming from growth hormone receptive area. So it will not going to come from where growth hormone is not going to act. So you don't want to waste your growth hormone. In a way, this is how it's working. And this growth hormone will then target it. They will chaperone it directly to its site of action. Okay, you come here and do the work out there in that regard. Now, very importantly, binding protein can also act like a regulating agents as well. Now, what I mean is that if you have a IGF-1, it's typically going to bind in a circulation to IGF-BP3. So if your IGF-1 level is too high, it may do harm to the body. It may cause oncogenic effect. So your binding protein will say, okay, I don't want that much IGF-1. I will drop it. I'll decrease the effect and make it smooth. So that is why if you give direct IGF-1 versus when you give growth hormone, with growth hormone, both IGF-1 and IGF-BP go up, and therefore your free IGF-1 is not very high. While if you give just direct IGF-1, your free IGF-1 may become very, very high, and you will have more of issues in that perspective. So clearly what we are seeing is that this IGF-1 will modulate its effect. So binding protein are not only transporting the hormones, it's regulating the effect of the hormone, and it is also taking them to their target sites from that regards and regulating from that perspective. Now, there could be disorders in which effect on the binding protein can have abnormal effect. So in hyperinsulinism, why do obese children tend to grow more?
These children has
so they will have more insulin, and this insulin will, so it will decrease the production of IGF-BP. So free IGF-1 is more, and that's why you've got more growth. So obese children are tall, but do they end up as tall adults? Why?
Yeah, in the important status, much more fat due to estrogen production, and that is causing the.
So because they produce too much aromatase also, that's why the estrogen becomes more, so bone fuse. So they are tall in childhood, but not tall in adults. The same mechanism is very, very important in the setting of polycystic ovarian syndrome. In polycystic ovarian syndrome, you have got selective insulin resistance. So you have got insulin resistance in different parts, but the ovaries remain to be insulin sensitive. So ovaries, your insulin growth will be more, plus your IGF-1 level is more also in that regard. So binding protein are important in terms of regulating the overall process in that perspective. And of course, they will have an impact in that regard. Then we discussed already that if you give growth hormone, both binding protein will go up. So free IGF-1 will not be increased in that regards. Other important thing is that the binding protein provide a stabilized level of hormones. So when we say about cortisol secretion, we say it's a pulsatile secretion. But when we really talk about the graph, we say a smooth sort of graph. That is because your binding protein provides stability to the hormone level in that regard. And this is particularly true for the cortisol secretion. So if you have a problem of binding protein, the stability will go up in that regards. Now, having said all that, the binding proteins are saturable. So they can only take care of a particular amount of hormone. If you have too much of hormones, what will happen then? And you may lose it also. So this has very, very significant implications in treatment of acute adrenal insufficiency. What implication are you thinking of?
If we give a continuous infusion, then other binding proteins are more likely to get saturated and give a stable cortisol distribution.
Yes. So if you have a cortisol level above 700 nanomoles per liter, you cannot keep it bound. It will be high. It will go in the urine. So if you give 50 milligrams of hydrocortisone in acute adrenal insufficiency every 6 to 8 hourly, you will have rapid shoot up, but the levels will go down. While if you give a continuous infusion, as Dhwani was talking about, you will have a more stable level. And there again, this binding protein effect becomes absolutely important. And you will have a stable amount of binding protein. Now, binding protein modulation is also a way in which you treat a particular individual. So which condition, which endocrine condition, you get a good response by changing the level of binding proteins?
The
estrogen.
Is the right
Sex hormone binding globulin, yeah.
First,
Yes, very important. So the major mechanism why your estrogen works in polycystic ovarian syndrome is through this mechanism, that estrogen is more, sex hormone binding globulin is more, testosterone level may be high, but your total testosterone level will be high, but free will be low. And therefore, you will have less impact on that regard. So this is a way in which you can actually treat a particular condition. Now, binding proteins are affected via various parameters, and we know that thyroxine binding globulin is particularly increased by anything related to estrogen. So we know that in pregnancy, the levels may go up. With estrogen treatment, the levels may go up. So if somebody is on thyroxine and you give an oral contraceptive, the requirement will go up. Because normal individual will be able to compensate. They will produce more thyroid hormone. But if you have deficiency and you're entirely dependent upon your external agency, you will say, okay, 99% is already bound and now my binding is more, so I need more amount of thyroid hormone. Androgens, on the other hand, and anabolic steroids tend to suppress TBG production in that regards. SHBG, which we already discussed very nicely, that estrogen increases its level and androgen decreases the SHBG level. So in individuals who have got androgen excess, the total testosterone, is it a more sensitive or a less sensitive marker of androgen excess? Yeah. So total level may be falsely low. So if your total is high, it is high. But if your total is normal, you may still have a high free testosterone level, and that becomes important from that regards. Similarly, CBG is affected via all the other parameters. So during pregnancy, your requirement for hydrocortisone may be high in that perspective. Now, one very interesting scenario of quote unquote a binding protein or a transport protein is highlighted by this case. 1-year-old boy with severe mental retardation has a low T4, normal TSH, and a high T3. There is severe spasticity. There are extrapyramidal symptoms, look extremely developmentally delayed. What do you think would be the cause here? Yeah. Yeah.
apparently.
At high level. So it's like you're swimming in the sea, but you can't use that. So your thyroid is very high outside, but it cannot enter the cell. Like in type 1, your glucose is there, but you can't get into the cell because insulin is not there. So the problem here is in the MCT8.